Welcome back to the deep dive. Today, we are doing something a little different.
Yeah.
Usually we take a stack of articles, maybe a trending topic, and we just, tear it apart to find that nugget of truth. But today, today we're going to be your high-yield study companion.
Right.
We are tackling a beast.
A literal heavyweight champion of medical literature. I mean, if you drop this book on your foot, you're going to need an orthopedic consult, not a urologist.
We are diving deep into the Bible of surgery itself, Baily and Love's Short Practice of Surgery. And we're talking about the 28th edition. We're zooming in with laser focus on chapter 83, the urinary bladder.
It's such a fascinating chapter because the bladder is, it's deceptive.
It's deceptive? How so?
Well, on the surface, it seems like the simplest organ in the body. It's a bag. It holds water. It lets water go. It's a balloon.
But when you actually open the hood, as Baily and Love reveals,
it is a masterclass in physics, fluid dynamics, neurology, structural engineering. And when it goes wrong in these really specific, logical ways that tell you exactly where the problem is, if you know how to listen.
So our mission today is to interpret and decode this dense medical text. We want to turn Chapter 83 into a ready reckoner for you.
Mm-hmm.
Whether you're a medical student sweating over finals, a surgical trainee preparing for the boards, or, just a lifelong learner who wants to understand their own plumbing, we are going to move beyond just regurgitating the fact.
Right. Facts are cheap. You can look up facts on your phone. Concepts are expensive. We want to give you anchors, metaphors, these conceptual frameworks so this stuff actually sticks in your brain and stays there.
Exactly. Now, a quick disclaimer before we fire up the engines. We are interpreting the source material to help you understand it. This is a study companion. It is not a replacement for the textbook.
So important.
We're giving you the match, but you still have to walk the territory. So please, read the original chapter for all the fine print. Expert, give us that roadmap. Where are we going today?
Okay, so we're going to break this massive chapter down into 4 distinct quadrants, just to keep it organized in your head.
Good.
First, we'll look at the plumbing and wiring, the anatomy, and the surprisingly complex physiology of how we, store and void.
Okay.
Then we look at when the blueprint fails, so dealing with congenital defects. From there, we tackle the functional disasters, incontinence, and neurogenic issues.
Right.
And finally, we'll close out with fire, fibrosis, and growths, infections, inflammations, and tumors.
And to keep everyone on their toes, I've got some checking questions and a few fictional mini-case studies loaded up to test your recall in real time. So no zoning out.
Let's get into it.
All right, Section 1, the wiring and the plumbing. When I picture the bladder, I honestly just picture a rubber balloon. Is that fair, or am I sort of insulting the organ?
You're insulting it a little bit.
Yeah.
It's a starting point. But Baily and Love describes it more accurately as a viscoelastic tank.
Viscoelastic. Okay, that word implies it's not just passive.
Exactly. A balloon just stretches until it pops. The bladder has active properties. To really understand it, you have to think about it in layers. On the very inside, you have the urothelium.
Mm-hmm.
Now, for years, people thought this was just, waterproof lining, like the plastic liner in a swimming pool.
Just there to keep the urine away from the bloodstream. Simple.
Right. But we now know it's so much more than that. It is a barrier. Yes, it keeps toxins out. But it's also a scout.
A scout.
Yeah, it sends signals to the nerves about distension, pain, and chemical irritation. It releases mediators. It talks to the nervous system.
It's the intelligence on the border.
Yeah.
And wrapped around that scout is the muscle, the detrusor.
The powerhouse. And the text uses this specific phrase for the detrusor that often confuses people. A functional syncytium.
Okay, let's unpack that. Functional syncytium. It sounds like a term from a sci-fi movie.
It does, but it just means coordination. The detrusor is made of millions of individual smooth muscle cells. But because of how they are connected with these low-resistance electrical bridges, they act as a single unit.
Ah.
So when the signal comes to squeeze, they don't ripple like a wave. They contract all at once to generate pressure.
So it's an all-or-nothing event?
Effectively, yes.
Yeah.
But the real magic, and the part that trips up every medical student I've ever met, is the neural control. The wiring.
Oh, absolutely. The sympathetic versus parasympathetic battle. I remember staring at those diagrams in the library at 2 a.m., just trying to figure out which one opens the door and which one squeezes the bag. It's a nightmare to memorize.
It doesn't have to be. We're going to use a mnemonic anchor that simplifies everything. If you remember one thing from this entire deep dive, remember this phrase. Are you ready?
I am so ready. Lay it on me.
Sympathetic stores, parasympathetic pores.
Sympathetic stores, parasympathetic pores. Okay, let's break down the sympathetic stores part first. This is the fight or flight system.
Exactly. I mean, think about the evolutionary logic. If you were running from a lion or if you were in a high-stress meeting, do you want to stop to pee?
Definitely not. No. You want to hold it. You need storage.
So the sympathetic nervous system, and this comes from the spinal levels T10 to L2, it kicks in. It releases noradrenaline. Now, pay close attention to the receptors here because this is where the pharmacology, the drugs we use, comes in later.
Okay.
You have beta $3 receptors on the detrusor muscle itself.
Okay. Bet $3 on the tank.
When noradrenaline hits those beta $3 receptors, it relaxes the muscle. It tells the tank, chill out, expand, make room. We are storing.
So bet $3 makes the bag bigger.
Correct. But you can't just relax the bag. You have to close the door to prevent leaking.
Right, the tab.
And that's where the alpha $1 receptors come in. These are located at the bladder neck and the urethra. When the sympathetic signal hits the alpha $1 receptors, it tightens the tap.
Okay, so sympathetic stores works two ways. Beta $3 relaxes the tank to hold more, and alpha $1 tightens the neck to keep it in. And the result is urine stays inside.
Perfect. Now flip the coin.
Yeah.
Parasympathetic pores.
This is the rest and digest phase,
What?
when we are safe and, ready to go.
Right. This comes from the sacral roots S2, S3, S4. Baily and Love refers to this area as the spinal maturation center. When it's time to go, this system releases acetylcholine, and it targets the M3 receptors on the detrusor.
And M3 means squeeze.
M3 means squeeze. It contracts the detrusor to empty the tank. At the same time, that sympathetic tightening of the neck is inhibited. But we are missing one player, the one that makes us polite members of society.
The one we actually control, the somatic system.
The voluntary guard. This travels via the pudendal nerve, specifically from a cluster of neurons called Onuf's nucleus. This controls the external sphincter.
So that's the final failsafe. Even if the autonomic system is screaming, go, I can consciously say, no, not here, not in the elevator.
Exactly. That's the only part of this you actually have conscious control over. The rest is this autonomic dance between storing and pouring.
So let's recap the cycle just to make sure we have it locked in. In the storage phase, the pressure is low. The guards are active. Sympathetic is tight. Somatic is tight. The parasympathetic worker is, well, it's asleep.
Correct. You've got it.
Then, in the voiding phase, the brain, specifically the pontine micturition center, flips the switch. Parasympathetic fires. Sympathetic stops. The guard steps aside, and we pour.
You've got it. It's a perfect reciprocal relationship.
All right, time for our first check-in question. Listeners, I want you to really think about this. Don't just wait for the answer. Pause if you need to. Based on that receptor logic we just built, if I give a patient a drug that locks the parasympathetic system, an antimuscarinic agent, what happens to the bladder? Think about it. Sympathetic stores, parasympathetic pours. If I block the pouring,
The answer is
it stops the squeeze and helps you store.
exactly. If you block the parasympathetic system, you block the M3 receptors, you prevent the squeeze. This relaxes the detrusor. That is precisely why antimuscarinics like sulfanicin or oxybutynin are the frontline drugs for overactive bladder. They calm down the urge to pour by blocking the pour signal.
See, pharmacology isn't magic, it's just applied anatomy. If you know the wiring, you know the drugs.
Okay, let's move on to section 2. When the blueprint fails, we're talking congenital anomalies.
This takes us all the way back to embryology. And really, almost every congenital bladder problem comes down to one structure, the cloaca.
The common sewer.
A delightful term, isn't it? But it's accurate. In the early embryo, we don't have separate exits for urine and stool. We just have the cloaca, and it has to partition into the urogenital sinus, which becomes the bladder and the anorectal canal. Most congenital problems arise when this partition just doesn't happen correctly.
One of the most common things mentioned in Chapter 83 is bladder diverticula. I
Yeah.
always picture these like little hernias of the bladder sort of popping out like a bubble on an old tire. That's exactly what they are. A diverticulum is a herniation of the lining, the mucosa pushing through a weak spot in the muscle wall. And Baily and Love distinguishes between two types, congenital and acquired. And this distinction, it really matters for exams and for real life.
Okay, let's start with congenital.
So this is also called a Hutch diverticulum. It usually happens near the ureteric orifice, so where the kidney tube enters the bladder. It's caused by a congenital weakness in the muscle wall at that specific junction. The key thing to remember here is that the pressure inside the bladder is usually normal. It's just a weak spot in the manufacturing.
Versus the acquired type, which we see in adults.
Totally different mechanism. In adults, usually older men with big prostates, the diverticulum forms because of obstruction. The prostate blocks the door, the pressure inside the bladder skyrockets to push urine out, and that high pressure forces the wall to blow out at its weakest points.
So congenital is a weak wall, acquired is high pressure. Why are these diverticulas so dangerous? Is it just that they look weird on a cystoscopy?
No, they're functionally dangerous.
Yeah.
You have to remember, the diverticulum is just mucosa. It doesn't have the detrusor muscle around it.
Right.
So when the bladder squeezes to empty, the diverticulum doesn't squeeze. Urine just sits there.
Stasis.
And stasis is the root of all evil in urology. I mean it. Stasis leads to infection. It allows chemicals to precipitate into stones. And because the urine is sitting there with carcinogens, it's a breeding ground for malignancy.
Oh, wow.
And if you find a cancer in the diverticulum, the prognosis is often worse because there is no muscle layer to contain it. It goes straight through that thin wall.
That is a terrifying but really important detail. Okay, moving from hidden pockets to something much more visual and dramatic. Bladder exstrophy.
This is one of the most severe defects. Imagine the bladder is turned inside out. It's a defect in the abdominal wall where the bladder is actually exposed on the outside of the body at birth.
The text mentions a specific physical sign with this, the waddle gait. Why do they walk differently?
It's skeletal. Because the abdominal wall didn't close, the pubic bones, the front of your pelvis, never join in the middle. They are widely separated.
I see.
And that changes the geometry of the hips, leading to that waddling walk. You also see epispadia, where the urethra opens on the top of the penis rather than the tip.
Now, diving into a really critical concept for pediatric urology, neural tube defects, like spina bifida. The text talks about the safe bladder. That sounds like a strange term. I mean, aren't all bladders supposed to be safe?
You would hope so.
Yep.
But in a child with spina bifida, the nerves are damaged. The bladder might be spastic and high pressure. The expert priority here, and Baily and Lowe is very firm on this, is not necessarily making the child dry or continent immediately. The priority is protecting the kidneys.
How does the bladder hurt the kidneys?
It's all about pressure physics. If you have a high-pressure bladder, imagine the detrusor squeezing like crazy, but the sphincter stays closed. We call that dyssynergia.
Yeah.
The pressure builds up. It has nowhere to go but back up the ureters. Exactly. And that back pressure destroys the delicate filtration units of the kidneys. So a safe bladder is a low-pressure reservoir. We might catheterize them intermittently just to keep the pressure down. We save the kidneys first. We worry about dryness second.
Kidneys first, dryness second. That's a great anchor.
You can live with diapers. You can't live without kidneys.
Good point. Let's finish this section with Urcal anomalies.
The urechus, the ancient drain. In the fetus, the bladder connects directly to the belly button, the umbilicus. It drains urine into the amniotic fluid.
Right.
After birth, it's supposed to shrivel up and just become a ligament.
But sometimes it stays open.
Correct. If it's fully open, we call that a patent urechus. You literally leak urine from your belly button. If it closes at the ends but not the middle, you get a cyst.
Okay, time for a mini case study. Imagine a young adult, say 25 years old. They come in complaining of a wet belly button and a red, painful ring around the umbilicus. They thought it was just lint or an infection, but it won't go away. Antibiotics help for a week, then it comes right back.
That is a classic, textbook presentation of an infected urethral sinus. The diagnosis is usually confirmed with an ultrasound or a CT scan.
And the treatment? Just keep giving stronger and stronger antibiotics?
No, you treat the acute infection, yes. But once it cools down, you have to excise the tract surgically. You have to cut it out.
Why? Is it just a nuisance?
It's more than a nuisance. If you leave a urethral remnant, there is a distinct risk it can turn into a nasty type of cancer later in life, adenocarcinoma.
Oh.
Because the urechus is gut-derived tissue, it forms glandular cancer, not the usual bladder cancer. It needs to come out.
Got it. Okay, let's move to section 3, the leaking tank. Urinary incontinence. This is huge for quality of life.
It is. It isolates people. It causes depression. And broadly, to understand it, we divide the enemy into two camps: stress incontinence and urgency incontinence.
Let's define them clearly so our listeners can spot the difference.
Okay. Stress incontinence, SUI, is leaking on exertion. You cough, you sneeze, you jump on a trampoline, and you leak. The mechanism here is a failure of the floor or the seal. The pelvic floor hammock is weak, or the sphincter isn't tight enough to handle that pressure spike.
Okay, so it's a plumbing sport issue. And urgency incontinence, UUI.
It's leaking with a sudden, compelling need.
Yeah.
You're unlocking your front door, and boom, you have to go right now. You can't hold it.
Oh, okay.
The mechanism here is the muscle. The detrusor is overactive. It's squeezing when you don't want it to.
So stress is a weak door. Urgency is a hyperactive tank.
Ideally put, yes.
The text talks about investigating this with urodynamics. I love the analogy here. Test driving the car with sensors attached.
That's effectively what it is. You fill the bladder slowly with fluid while measuring the pressure inside. But here's the physics problem. The pressure inside the bladder, let's call it OKA, is a combination of two things: the bladder muscle squeezing and your tummy pushing down.
Right, because the bladder is inside the abdomen. If I bear down or cough, the pressure goes up.
Exactly. So to know what the bladder muscle itself is actually doing, is it spasming? You have to subtract the tummy pressure from the total pressure.
So detrusor pressure equals bladder pressure minus abdominal pressure.
Precisely. That calculation is the holy grail of urodynamics. It tells you if the leak is because the muscle went rogue, which is urgency, or because the floor gave way under pressure, which is stress.
Let's talk treatments because they are totally different for the two types. And this is where students often get confused.
They are opposites. If the problem is urgency, the muscle is too active, you want to calm the muscle. We use the sympathetic stores logic we talked about earlier. We give beta-3 agonists like mirabegron to relax it, or antimuscarinics to stop the squeeze.
And what if pills don't work?
Then we paralyze it. We inject Botox directly into the detrusor muscle. Or we can use sacral nerve stimulation to rewire the signal. It's like a pacemaker for the bladder. In really extreme cases, we do a clam cystoplasty. We slice the bladder open and patch it with a piece of bowel to make it bigger and floppier.
Okay, now flip it. Stress incontinence. The floor is weak. Pills don't really fix a broken hammock.
Right. You can't pill a hernia. This is a structural problem requiring a structural solution. So for women, we shore up the floor. We can use bulking agents to fill the gaps, or, more commonly, slings, either synthetic tape or the patient's own fascia to support the urethra.
And for men, usually this is after prostate surgery, right?
Yes. Post-prostatectomy incontinence is a major issue. We can use a male sling for mild cases, or the gold standard, the artificial urinary sphincter, or AUS. It's an inflatable cuff around the urethra that the patient controls with a little pump in the scrotum.
It's incredible engineering.
Yeah.
So check-in question 2. A patient comes to you. She leaks urine every time she coughs or laughs. She has zero urge to go beforehand. It just happens with the cough. She read about Botox online and asks if that will fix it. What do you say?
You say absolutely not. Her problem is stress incontinence, a plumbing support issue.
Sorry.
Botox paralyzes the muscle, which treats urgency. Botox won't fix a weak pelvic floor. In fact, by weakening the bladder, it might make it harder for her to empty voluntarily, which could lead to retention. She needs a sling or bulking, not Botox.
Clear as day. Match the treatment to the mechanism. Okay, let's get into the heavy stuff. Section 4. The nervous system disconnected. Neurogenic bladder.
This is the most complex part of the chapter, for sure, but Baily and Love breaks it down by altitude. Where is the injury?
Okay, let's start at the top. Suprapontine. So brain injury, stroke, Parkinson's.
Think of the brain's role as the inhibitor. It tells the bladder, not yet, wait for a toilet. If you have a suprapontine lesion, like a stroke, you lose that inhibition. The result is what we call the uninhibited child. The bladder squeezes whenever it wants. You get storage problems and overactivity, but the coordination is usually preserved.
Okay. Moving down, spinal cord injury.
This is the dangerous disconnect. If the injury is between the brainstem and the sacrum, say a T10 paraplegic, the coordination is lost. The bladder might try to squeeze while the sphincter is still clamped shut.
That dyssynergia again?
Yes. Detrusor sphincter dysynergy, or DSD, it creates massive pressure. It's like pushing a plunger down on a block syringe. And that pressure backs up to the kidneys. This is the highest risk group for renal failure.
And finally, the sacral injury. The lower motor neuron.
This is the floppy bag. You've cut the power cord, the bladder loses its tone and its ability to squeeze, you get retention and overflow incontinence, the bladder just fills up until it spills over.
Now, within spinal cord injuries, there is a concept that every doctor, every nurse, every healthcare professional must know. It is a medical emergency. Autonomic dysreflexia.
This is absolutely critical. It happens in patients with injuries above T6.
Walk us through the mechanism. It's a chain reaction, right?
Yes. So imagine a patient with a T4 spinal injury. They can't feel anything below the nipple line, but their body still reacts. Let's say their bladder is blocked and overfull. That is a noxious stimulus below the level of the injury.
Okay, so the body below the injury senses trouble, even if the patient's brain doesn't feel pain.
Exactly. The sympathetic nervous system below the injury goes haywire. It releases a massive surge of adrenaline. It clamps down all the blood vessels, Blood pressure spikes dangerously high. We're talking stroke territory.
Wow, so the brain senses this high blood pressure.
The brain screams, too high. It tries to fix it. It slows the heart rate bradycardia, and it tries to send a relax signal down the spinal cord to open the blood vessels. But
The signal hits the roadblock, the spinal injury.
exactly, the relax signal can't get past T6. So the vessels below the injury stay clamped, keeping the BP high. However, the vessels above the injury dilate massively because they did get the signal.
This leads perfectly to check-in question 3. I want you to visualize the patient in autonomic dysreflexia. We call it the silent scream of the body. Why is the patient's skin flushed and red on their face and neck, but pale and cold on their legs?
It's that split signal. Above the lesion, the brain is causing vasodilation to try and dump pressure. So they are red, flushed, they have a pounding headache. Below the lesion, the sympathetic surge is causing vasoconstriction, so they are pale and cold.
And if you see this, what do you do? What's the first thing you do?
Sit them up immediately to use gravity to lower BP. Then check the bladder. It's almost always a block catheter or a full bladder. Fix the drain, stop the surge. This is a situation where unblocking a catheter literally saves a life.
Life-saving stuff. Let's shift gears to section 5, structural failures, fistulae, retention, and stones.
Okay, let's talk fistulae. A vesicovaginal fistula, or VVF, is a hole between the bladder and the vagina.
And the text highlights a really tragic contrast between the developing and developed world here.
Truly. In the developing world, this is often a result of obstructed labor. The baby's head presses against the pelvis for days, causing pressure necrosis that just eats through the tissue. In the developed world, it's almost always iatrogenic, meaning caused by surgery, usually a difficult hysterectomy where the bladder gets nipped.
The patient presents with constant leakage, but sometimes it's subtle. How do we diagnose it without fancy machines? The text mentions the 3-swab test.
This is such a clever low-tech diagnostic that you can do anywhere. You place 3 gauze swabs into the vagina top, middle, and bottom. Then you fill the bladder with blue dye.
Okay, so you just watch for blue.
Exactly. If the top swab is blue, the leak is likely high up, maybe a ureter injury, if the dye was given IV, or a high-volt fistula. If the middle swab is blue, that's your classic VVF. And if the bottom swab is blue, it's likely a urethral leak, or even just stress incontinence. It helps localize the hole before you operate.
Simple but so effective. Now, retention. We have acute and chronic.
Acute is painful. You know about it immediately. The patient is climbing the walls. Chronic is the silent danger. It's painless. The bladder has stretched so slowly over years that the sensors have desensitized. These patients can have 2 or 3 liters of urine inside and not feel pain.
The danger here is high-pressure chronic retention.
Right. Because if the pressure is high, the kidneys are failing. And when you finally put a catheter in to drain it, you have to watch out for post-obstructive diuresis.
The text calls this the polythene bag effect.
Exactly. The kidneys have been blocked for so long they've lost their ability to concentrate urine. Once you open the tap, they just dump fluid like a cheap plastic bag with a hole in it. Patients can lose massive amounts of water and electrolytes in hours. You have to monitor them very closely, or they can go into shock.
Briefly on stones.
Stones in the bladder. Primary stones are seen in kids in developing countries, offer nutritional, low-protein, high-carbohydrate diet. They're usually ammonium urate. Secondary stones are what we see in adults with obstruction. The urine sits, gets infected, and forms stones.
And the visual anchor here.
The jackstone calculus. It looks just like those little metal jacks children used to play with, spiky, distinct points. These are usually calcium oxalate. If you see a spiky stone on X-ray, think jackstone.
Moving to our final clinical section. Section 6. Fire, fibrosis, and growths. Infections and cancer.
Let's start with UTIs. We tend to think of bacteria just floating around in the urine. But Baily and Love explains why they're so hard to kill.
The bunkers.
Yes. The bunkers. Bacteria form intracellular bacterial communities, IBCs. They actually invade the urothelial cells, the lining we talked about earlier, and build fortresses inside them. They hide from antibiotics and the immune system, waiting to break out later. That's why you get recurrent infections. The enemy isn't just on the field, they're behind the walls.
Now, there are 3 special inflammations that are absolute quiz essentials. TB, schistosomiasis, and ketamine. Let's rapid fire these.
Okay. TB, tuberculosis. It causes sterile pyuria. That means you see pus cells in the urine. But standard cultures grow nothing because TB needs special cultures. It causes severe fibrosis, leading to a thimble bladder, tiny, scarred, and useless.
Schistosomiasis.
The traveler case. Someone who went swimming in fresh water in Africa or the Middle East. It's caused by a fluke. The egg has a characteristic terminal spine. It digs into the bladder wall like a thorn.
And the risk, the long-term risk.
Calcification, you see sandy patches on the bladder wall. And specifically, squamous cell carcinoma. Not the usual cancer. It's an aggressive cancer caused by chronic irritation.
And the third one, a modern epidemic, ketamine cystitis.
We see this in young people using recreational ketamine. The drug metabolites just destroy the bladder lining. It becomes a small, contracted, fibrotic, incredibly painful organ. It is often irreversible. We sometimes have to remove the bladder in 20-year-olds. It's devastating.
That brings us to the big C, bladder cancer.
The golden rule. Painless haematuria is cancer until proven otherwise. If you pee blood and it doesn't hurt, you need a camera in your bladder. Do not just treat for a UTI and hope it goes away.
The most common type is transitional cell, or urothelial, but the staging is the cliff edge concept.
Right. So you have Ta and T1. These are on the surface. We can scrape them away with the scope. Then you have T2. T2 means the cancer has invaded the muscle, the detrusor.
Why is T2 the tipping point?
Because once it's in the muscle, scraping isn't enough. The vascular supply is rich there, and the risk of spread is high. T2 usually needs radical cystectomy. The whole bladder has to come out. That is the life-changing line in the sand.
Okay, check in. Question 4. A patient has a calcified bladder visible on a plain X-ray. They have painless hematuria. They mentioned they lived in Egypt for a few years as a child. What specific cancer are you worried about, and why isn't it the usual one?
You are worried about squamous cell carcinoma. It's not the usual transitional cell carcinoma because the chronic irritation from the schistosomiasis eggs drives the cells to change type metaplasia into squamous cells. It's a different disease process.
Perfect. We have covered a massive amount of ground, from sympathetic stores to the dangerous dyssynergia to the thimble bladder.
It's a journey through physics, chemistry, and structure.
So what is the final provocative thought for our listeners to take away from all this?
I want you to think about the bladder as a social organ.
A social organ.
Think about it. It is the only autonomic organ under voluntary control. You don't tell your heart when to beat or your stomach when to digest, but you tell your bladder when to empty. Why? So we can function in society. When the bladder fails, incontinence, it results in social isolation. People stop leaving their homes. When it causes pain, like in ketamine cystitis, it destroys lives.
Yeah.
When it fails to store properly, like in neurogenic bladder, it destroys the kidneys. It sits right at the intersection of our biology and our social existence. Respect the tank.
Respect the tank. I love that.
And my call to action for you listening, open Baily and Love, Chapter 83. Look at the diagrams of the nerve pathways. Look at the pictures of the jackstones and the diverticula. Use this conversation as your skeleton, but go put the flesh on the bones with the text.
That's it for this deep dive. Keep curious, keep learning, and as always,
Keep diving deep.